Good evening, everyone. Welcome to the Global Day program of IUB, orchestrated by the Global Studies and Governance GSG program in order to commemorate the UN Day, which is on the 24th of October. Now, for a second, why am I saying Global Day? Yes, we at the GSG program at IUB have baptized the UN Day to Global Day. Now that we all know where we are in the cloud, let me take you to the exclusive panel of today's program. COVID Unravelled. I welcome all distinguished panelists who have joined us to share the experts' insights. Yes, this year the UN theme is food security and health, very much that is being affected by the pandemic, as consequential and as deadly as the coronavirus pandemic has been and will continue to be. We are here to discuss how our very own country, Bangladesh, is unraveling the COVID-19 pandemic. In that context, this panel will share with us how Bangladesh has managed the food security issues and supply chain management, and most importantly, how the pandemic has impacted the lives of 9 million plus refugees and host communities, and how the humanitarian assistance is at their disposal. Before we begin, the rules of the game: each panelist will have 12 minutes to discuss their paper, which will be followed by discussion sessions, question answers from the students, and then we have our favorite Professor Imtiaz Hussain to give us the closing remarks. If you have any questions for the panelists, please do not hesitate to drop it in the comment box of our Facebook page and YouTube link. And without much ado, let's take the hike. And the first person I present to you is Dr. Meghna Guha Thakur, Executive Director, Research Initiative, Bangladesh. And she will be presenting on facing COVID-19, Rohingya, and the host communities. Dr. Meghna Guha Thakur, the floor is yours.
Thank you, Jessica. A very good afternoon to all of you, my fellow panelists, as well as the staff of IUB, as well as our participants. Today's topic is a very close one on the basis of what Research Initiatives Bangladesh has been doing during the last year. And of course, through being present in that area, we've had a chance to link up to our participants in the field in the Cox's Bazar area, both Rohingyas and the host community. And I will be talking about that basically. But before that, I would like to introduce to you the background of COVID in Cox's Bazar itself. When we look at the newspaper reports, we see that the first instances of COVID that was publicly publicized in the newspapers was basically as a result of some forced returned migrants from the Middle East, which arrived at Cox's Bazar airport, and that's how the newspapers got hold of the report, and it spread. And immediately there was, ever since we started lockdown around, very late March, there was always this fear that was being expressed by official circles as well as by civil society that what on earth will be happening in terms of the refugees, about almost 100,000 refugees that has been, in the area since 2017, August. And the thing is that the occurrences of this COVID was based on certain stereotypical kind of notions that, incidentally enough, was shared both by Bangladeshi official circles as well as the Myanmar official circles, because which is very, in a way, stigmatized opinion that wherever the Rohingyas, because they are least underdeveloped and underserved community, they will be carrying the virus because they also live in congested spaces, they will be spreading the virus into the host population. Actually, it happened the other way around. We know that from the host community, it was found much more earlier in the host community, in the local communities in Cox's Bazar, and then only we hear of its occurrence in the refugee camps much later on in the lockdown period. However, I think we also have to realize that the stigmatization as refugees sort of doubled up or was exacerbated by the COVID-19 syndrome. They were stigmatized as refugees, they were stereotyped as being hostile, as being, the xenophobic tendencies were exacerbated in the local community, and there were tensions between the two. And on top of that, the COVID-19 brought in even more fears about it. We do, however, see that there were concerns also in the earlier preparation of COVID-19 for Rohingya refugees. I know that several NGOs who were in charge of implementing or in charge of site management were actually asked to build extra graveyards in certain areas in anticipation of deaths, a huge number of deaths. But fortunately enough, the number of deaths were not as much as we expected. In fact, very few, in fact, although a recent report from Amnesty International says that not enough has been tested. Even then, the number of deaths have been much more contained than was earlier expected. And that's a good sign for us, definitely. I think also one has to take into account the learning curves in administration, because soon after 2017 influx, there was an occasion also where there was instances of diphtheria being found in the refugee camps, and then also there were these fears being voiced by unofficial circles. Oh my God! Now we had gotten rid of diphtheria from Bangladesh, and we were trying to get herd immunity, but the existence of Rohingyas and diphtheria in the camps just prevented us from achieving this herd immunity. A lot of observations in medical circles and debates going on, but even then that was curbed. And very interesting enough, it is, I think, globally also, if you look at those Asia-Pacific, in the Asia-Pacific region, especially the Southeast Asian countries who have had SARS before and had built there and invested in institutions in trying to combat SARS epidemic, they were the ones that were in the front line of preventing COVID-19 as well. Taiwan, Singapore, they all, because the infrastructure was in place for this testing, tracing, and treatment cycle. They were used to it. And so I think also it's a good notion to know that what our learning curves are. So when I'm talking about what's happening now in terms of Rohingyas in the host community with COVID-19, hopefully we will be able to learn a lot in terms of the future in how to cope with the future pandemics, which we have been promised also in the years to come. So from here, I will just go on to what RIB has been doing. From 2019 April, RIB is Research Initiatives Bangladesh, our organization, who work with marginalized communities. And we've been working in Cox's Bazar region in different forms from 2011 onwards, but with the registered refugees. But so this was the first time we went back into the field after the 2017 And our project was basically about trying to mitigate tensions or handle the tensions between host community and the Rohingyas that were taking place. And I think it was basically the fact that we wanted to work both with the host communities. Even before the government made it mandatory to do so, we went there to the host communities and we addressed them. And our method of working is participatory action research, where we form groups, and we also give training on our right to information to the citizens, which are the host community people. And for Rohingyas, we also got them into groups of participatory action research, self-help groups to define their own agenda and get them into a problem-solving mode by prioritizing their agenda and taking action on it, however whatever form that action may take, and whatever is possible. But the whole idea is to get themselves to discuss about it and in a kind of a dialogical process. So we started working with basically 12 groups, 6 in the host community, 6 in the camps. We work in 4 camps, 2 in Ukia and 2 in Teknaf, Upazila. And also our local community groups are also in both Upazilas, the Ukia Upazila and in Teknaf Upazila. And male, in terms of male and female, we tried our best to make them 50-50. Some of the groups there have been problems with getting female participation in some of the more conservative areas, especially in the Rohingya camps, where they agreed to have women and men meet in a group, but they had to be where they could not find a venue for a meeting. They had to sit in the shelters of the Majis, the leaders' home, and therefore they were partitioned. So in fact, it was like the old days in Bangladesh when the NGOs were starting and they had to go to the rural areas where they met women for the first time across a bamboo partition or something like that. So it was quite an interesting experience for our facilitators there. Going on to, and since we have short of time, I'll go straight on to the fine. During the COVID, when COVID started, so our work stopped basically, and we still haven't got the permission. We had to seek extension. There was a lot of bureaucratic process in that, and still we haven't been able to re-enter the camps because we're waiting proper permission. Up till the time that we stopped our work, which was around March 2000 this year, we were able to also keep in touch with our group members through phones. And we decided to do a kind of a phone-in kind of interviews with them over a period of time when COVID was going on, because we wanted to know how they were coping. So this is basically what our finding was, which is very qualitative and very subjective, but will give us some idea about what was going on and how both local communities and Rohingyas coped with them. So first of all, in the terms of the Rohingyas, they said that of course, there were critical services which were kept going on in the camps. Critical services consisted of food, health, gas, and water, as well as and sanitation. So they said they continued to give the services. Food was given at the same amount that was given in the normal period, and but however, in terms of education, in terms of construction works for houses, new construction works, those were closed down. The RRC often came to inspect the camps, but the office, the camp offices were closed for some time, so they could not go there to avail of certain services, which or complain or air their grievances to the officers for a long time. Within the camps, there was no restriction on mobility, but once the reports of COVID-19 affected people turned up among the Rohingyas, we found that, and then there was checkpoint as installed in just outside the camps to stop the local population from coming in. They generally said they had received a lot of awareness programs on how to conduct themselves, masks, hand washing, but many said that the masks that were given through their leaders, the Majis, but all of them did not receive. And these are feedbacks we got from our groups. I mean, other groups in the camps may have different findings, but our groups, I must say that we have chosen specially those areas which are quite, in remote areas, not remote so much, not so accessible to official visits and not within the camp, not within the range of the camp office. So, for example, in Noyapara, they might be nestled inside a hill, or in the foothills of a hill. So, so basically access to certain services was still missing there. And because the camps were closed down for other NGOs, the cash for work that was going on in many of the projects, they were deprived of that. And that was an important thing. And mostly important was the fact that violence against women were not considered to be a critical service, unless you were physically affected and it came into the health sector. But in terms of abuse or general domestic violence, many of the NGOs who were working within this range were not allowed to go into the camps. So, and instead, much of the camp gender-based violence was being arbitrated by the local leaders and the majlis and the imams of the mosques. And there was no oversight, which is generally there among the implementing agencies. There was no oversight there of these arbitrations as much as they could have been if it were open. So that was a big critical problem for them. In terms of the local community had been talking a lot about their problems even before COVID came. And basically they were, so they were basically looked at as the fact that there was rising of the prices of vegetables, which became even more. The restriction of mobility affected the local population a lot because they could not go out. The military checkposts as well as police checkposts were there. And they said that even if one person wanted to go to the bazaar more than once or more than or several times, they were stopped. Of course, they are usually checkposts anyway, and they do harass women, especially those wearing burqa, because because of the yaba trafficking and the human trafficking, they want the women to be, lifting their burqa up, and it creates quite a lot of problems for the conservative area that they live in. So it has been, these are being quite the issues. They said that generally a lack of economic livelihood was the main problem that the local community faced. In terms of health-wise, the most nearest kind of health service they could get was these pharmacies, which also had some doctors in the within them giving service. So they could go to these pharmacies for health service. Sometimes the health complex was too far, and there was restrictions on mobility, which prevented them from going there very easily.
Dr. Meghna, you just have 2 more minutes.
Yeah, I will wrap up. So in terms of instability, or in terms of harassment, and the increasing use of narcotics, increasing house rent, these were all the problems that they showed. And many have been driven to take loans from their nearest neighbors, but some said that even the nearest neighbors, the grocery stores, could not give them credit because they themselves also had no food on the table. And there was, in general, a lack of services in terms of stimulus packages that was given. They did not know of any relief and recovery packages and they also did not receive any, mostly because they came from, they were not well coordinated. So the learnings that we get from this whole thing is basically that, one, I think that in the Rohingya camps, and later on, violence against women was considered to be a protection issue, and camps, when they opened, did allow this facility to come in. But I think violence against women in any kind of emergency response should be considered a critical service. That's one of the learning points. And in terms of there should be more coordination in the government circles of relief and recovery, who is responsible, more information about what is being handed out. And in terms of social cohesion, there were problems there were a lot of ethnic community people also living in that area, which faced, because they were mostly Buddhists, they faced a lot of intimidation from the Rohingyas, or fear of them from the Rohingyas, because many of them are racially like the Rakhine people back home. So they had to take extra precaution of attacks. And basically, we think that in terms of social cohesion, it should be more gender-based and looked upon that whether gender inclusion and diversity is also a part of the social cohesiveness that can act as a support for resilience during emergency. Thank you.
Thank you, Dr. Meghna Thakur. It was really wonderful knowing the everyday minute realities of the Rohingya people and the host community. However, we now move on to Dr. Mamoon Habib, professor in the School of Business and Entrepreneurship at IUB. And his theme for today is COVID-19 and supply chain management in Bangladesh. Dr. Mamoon, the floor is yours.
Thank you so much. First of all, I'm so much delighted as I'm invited in this program. Basically, we'd like to start my session by the supply chain management. So what we mention everywhere that still this concept supply chain management is not very familiar in our country. But today we have to talk about the supply chain management in Bangladesh based on the COVID-19 impact. Before going to start this discussion, I'd like to mention something about the supply chain. Can you see my slide? My slide is visible?
Yes, it is.
Yes, it is.
So when the COVID-19 started, the question is there in the supply chain that about the centralized production, just-in-time manufacturing, our rigidity could be to blame. So when you think about the impact of supply chain during the COVID-19, we have to think about these few phenomena. In the during the coronavirus disruption, one thing has become particularly clear to us: the way we design the supply chain, it is vulnerable to a pandemic time. As you know, that the history of supply chain management or evolution timeline of supply chain management. Supply chain management officially they started their journey by the name of logistic management in 1950s. And the supply chain management, they started their original name by the supply chain around the 1980s. And you see the 1980s and now 2020, only 40 years. So it's not too much long time that supply chain management research going on. And if you look very carefully, if you listen the news of the CNN, and even if you look very carefully, the press conference of the Donald Trump, president of USA, most of the time they try to say supply chain disruption during the COVID-19 time. But we are not familiar with this kind of term in our country because our people still we don't know about the whole supply chain concept. So today, my one of the target is a little bit a discussion of the basic idea of supply chain management, how it's impacting our country, Bangladesh. I like to start with one example, global example, then we come to the Bangladesh example. I think you know that Apple's, the top 10 suppliers, more than 2 and 3 are located in Asia, leaving the company exposed to COVID-induced factory shutdowns. And they're planning to leave into the China. I'll discuss again about this part later on. There is a most important impact of COVID-19 after the when the situation was deteriorated in the China. So now come to the point is that what is supply chain? If you ask in this way, we have to think about the chain. That chain will start from supplier and finish the customer end. And now we have to think how we could maintain this chain, and then from supplier to the customer end. So we have to think of the raw materials. We have to think of the finished product. We have to think of the supplier end. We have to think the customer end. That we have to think of the demand, we have to think of supply, we have to think of the flow of goods, flow of service for service industry, flow of goods for manufacturing industry. We have to think of the flow of information. It's very important during the COVID-19 time that how we could ensure that integrated information, how we could ensure that that all kind of information will be transparent and visible, the whole supply chain from the supplier to the customer. And finally, the flow of fund, flow of money. So when you design anything about any supply chain phenomena, we have to think of these three basic entities. This is a basic supply chain for the manufacturing industry. When you think the manufacturing industry, then we have to think of the supply end to the customer end. We have to think the manufacturer, distributor, retailer. So you know that when you think that like warehouse or the like this inventory, that we have to think about the inventory of the raw materials. That means the supplier and manufacturer. We have to think about the like the inventory of the finished product between the retailer and customer. So today, when I deliver the few phenomena about the supply chain, I hope that you can understand that what kind of impact we are facing in this COVID-19 time. This is a basic supply chain in our service industry. So that means again you can see there is the raw materials come up from the supplier and then the service provider. It could be like hospital supply chain management or university supply chain management. And then definitely the finished product delivered to the customer and finally to the consumer. If you think that like the service and the supply chain management, then we have to think how we could add the values to the society or end customer. And what I said that I just show you the simple model of the supply chain model for manufacturing industry and service industry as well. So now come to the question how we can apply the supply chain concept. We can apply the supply chain concept everywhere, like the manufacturing industry, like the vegetable supply chain management, what happened during the COVID-19 time, poultry supply chain, fishing supply chain, ready-made garments in the supply chain, textile in the supply chain, pharmaceutical supply chain, and so on. So now come to the point of the like, if you ask the supply chain impact during the COVID-19 time in service industry, same procedure. We have to think education supply chain, what type of impact we are facing. We are now, everything is online based. Now question is that whether the acceptance level of the online platform, whether our students, they are getting the knowledge or not, how we can do the assessment. Hospital supply chain. I think you know that during the COVID-19 time, we are facing the problem, shortage of PPE, the suppliers of PPE. This is a long discussion that why we are facing this one. So you have to again understand the supply chain. So similarly, service industry like the banking industry, tourism industry, and others industry as well. So what I said that if you think that like supply chain management, we have to think that the impact of supply chain management due to the COVID-19, all industry in the manufacturing or service industry is visible. As we have a time constraint, we cannot discuss everything in the one session, but at least we like to basic idea about the impact of supply chain management, especially in our country. First of all, the coronavirus has revealed the fragility of the modern supply chain. It's very important discussion nowadays. what we design the supply chain, what I said that we never think about the pandemic came earlier. So our designing supply chain and now our supply chain, the application of supply chain due to the COVID-19 totally changed. The first one is that fragility. So now we have to think about this one. In the last two slides, I'll give some considerations and recommendation how we can manage the supply chain in the COVID-19 time. Diversify sourcing. You know that most of the cases our raw materials comes from the one way, one suppliers. And during the COVID-19 time, I know that many manufacturing industry, many garments industry, they face this problem. Suppose that the only one component of their product comes from the China. So China, they started their lockdown in the January. So Bangladesh, many factories, they are waiting only for the one component because it comes from China. And they could not think earlier that how we can get the alternative the suppliers. So this is another issue is that what I said earlier, that diversified sourcing, diversified suppliers is required. Digitization, all information should be digitalized. And that is another challenge in our country in Bangladesh. Basically, you know that our paperwork is very common phenomena everywhere. So how we can move to the paperwork based to the paperless work schedules is not very easy, but we are trying to cope up. But I would say that it is not up to the standard level, but it will take time. Because I believe after this pandemic time, now we have to think newly. We have to design our thinking, how we can move to everything digitalization, so that there will be no question further if we face this pandemic next time. So what do you understand that this kind of diversified sourcing, digitalization will be the key to building the stronger, smarter supply chain and ensure the lasting recovery. Our main target, how we can recover, how we come to the normal stage. You know, the initially COVID-19 pandemic has the global trade and investment at the unprecedented speed and scale. I still recall that when the COVID-19 started, then the end of the last year, December, in China, we thought that maybe it will be for temporary time, it will be happen. But then it's chronologically spreading to the different country. When it moves to our subcontinent, like Bangladesh, India, in the March, then we understand that multinational companies faced an initial supply shock. So the first initiation was that supply shock. Then it goes to the demand shocking. So supply shocking with the raw material side, raw materials to factory side. They face the initial problem. Then they got the next problem, the demand shock. Because more and more countries order people to stay at home, so they couldn't get enough customers. Those in our country, those organization, factories, they do the export business. They're facing this problem. They couldn't send the products, and this is the way that how they have to stop their business. Our governments, businesses, and individual consumers suddenly struggle to procure the basic products. So basic products for raw materials, and were forced to confront the fragility of the modern supply chain. Initially they planned, but initially the thought was that maybe it will be there another 2 or 3 months. Hopefully it will be recovered. Even I still recall that when the March and our university closed, our all organization closed for the 1 month, 2 months. We assumed that hopefully within the next 4 to 5 months it will be recovered. Unfortunately, the situation was not like that. So that is the one thing what I said that fragility of the modern supply chain. Now, the urgent need to design the smarter, stronger, and more diversified supply chain. So it is one of the lessons during the COVID-19 time. What I said earlier, that if you look very carefully, supply chain disruption. I show you earlier that basic supply chain for manufacturing industry and service industry. If you look very carefully, disruptions gradually being felt everywhere, from ports to factories. I'll give the one example of the Bangladesh perspective based on our ports. And then store houses, a delivery channel. So look very carefully, ports to factories, storehouse outlet problem, distribution channel problem, delivery channels problem. And then disruption again is coming to our transportation, warehouses, because we have a limitation of capacity in the warehouses. So we cannot keep the raw material for a long time. And in the finished product, if you could deliver, if you could get a good number of customers, initially our traditional approach of the shopping, the people they have to go to the shopping mall. Unfortunately, it stopped. Now it's changing. I think everybody now notice online shopping. Now it is very familiar. So we are trying to move into that what I said earlier, digitalized everything. And everything will be the online based. So now we are moving to that kind of supply chain, what I said earlier. Disruptions were available in the suppliers of raw materials, procurement, distribution, Earlier that we have the suppose we have an option only one suppliers. Now we think that one supplier not sufficient. We have to go to the next 2 suppliers or 3 suppliers. You know that some of the in our country, I think you already noticed. Suppose in the Dhaka area, like nearby Dhaka area, like Narayanganj, Kajipur, there is a COVID-19 affected people, lots of people. But if you go to the rural area, it's not like our Dhaka situation. So it means that nowadays we have to think about this one, how we can divide our the production, how we can divide our market segment based on the the area based, based on the city based, so that we can get the customers and we can get the also the we can produce the products in the local based on, and so that we can also distribute the products among the customers, the local based. Disruption is also evident in the rural farm level, where the people are not getting fair prices of their production. It happened in our country and the initial level of the COVID-19 time. I'd like to give you the one, just an example of this one, that supply chain disruption in Bangladesh. If you look very carefully here, basically, when you talk supply chain, there are 4 pillars, like planning, sourcing, making, and delivery. So basically, this discussion is based on the April and May. But if you ask me now, the situation already changed. At that time, we assumed that the planning was good. We thought that we can recover. Sourcing, making, delivery was the bet. But if you ask me now at this stage, in the month of October, the planning also bad, the sourcing, making, delivery is the worst. So now we are facing this kind of impact of COVID-19 with the whole supply chain. And it's very interesting thing is that our activities in Chittagong port in Bangladesh have come to standstill as the amount of import containers has exceed the port stress capacity. And due to the slow delivery of goods and shutdown. It's very interesting thing is that we could not get the enough human resource, we could not get enough transportation, how we can deliver our products from the ports to the factory. And not only that, at the time, around the April, some 11 vessels were waiting at the jetties to offload the goods. And in addition to that, another 30 container vessels were waiting at the outer anchorage for the berthing. So look very carefully. Even our storage capacity was beyond the port's capacity.
I think some technical glitches on part of Dr. Mamoon. We'll just wait for a few seconds. Ladies and gentlemen, we'll get connected to Dr. Mamoon. However, we just move on to our next panelist, and once Dr. Mamoon comes back, then we will just pick up from there. Our next panelist is Dr. Muhammad Sarwar Hussain, Associate Professor, Department of Environmental Science and Management. And
hello.
I think we have Dr. Mamoon back with us. And Dr. Mamoon,
I'm so sorry.
It's okay. Can we just wrap up in 2 minutes?
Yeah, we can. I can. Thank you. Thank you so much. Can you see the slide, right?
Yeah, we can see the slides.
Yeah. Okay. So what I said that if you look very carefully that our situation in our country, the conglomerates, what they mentioned that they're facing the disruption in Chittagong port, production factories, and transportation as well. Our Magna Group, Bosundara Group, City Group, Abul Khair Group, they're also facing disruption in the supply chain and shutdown. So the more resilience, flexibility in supply chains, this is one options for them, how they can solve this problem. And now this is a question that suppose we can do the building up the stockpiles, buffer inventories to provide the more given the system, but warehousing comes at greater cost. So when the warehouse cost will be higher, there's a problem issue will be their cost will be increased. And maybe this is another challenge we can think that just-in-time delivery would be the one kind of solution. But I do not talk about the international supply chain disruption. I like to go back to this one. Basically, now come to the point how we can solve this kind of supply chain disruption in Bangladesh. We have to build that agility and speed into our supply chain by creating the micro supply chain. Now we had this time we have to see micro supply chain, the more finite, decentralized, agile, mini operating models. Maybe the local based on the like the one city, based on the like the one site, then we have to design this way. With the flexible supplier contracts and relationship with the manufacturer closer to the point of purchase. So now we have to go for this strategy: buy where we make and make where you sell. Easy way to get the access. We have to think the supply diversification, what I said earlier. We have to think about the supply chain strategize, move away from an adversarial short-term approach toward a long-term strategy. And I would like to recommend the last one that what we said that we have to now think how we can digitalize a buyer-supplier relationship. That is our fundamental element for building the robust supply chain. And we'll make the identify and recruiting the new suppliers far less time consuming. It could be possible if you apply the technological advancement like artificial intelligence or maybe the Internet of Things, as we are working on the Industrial Revolution 4.0. So maybe this kind of technology advancement, supply chain could quickly switch to alternative providers when the regular suppliers face disruption. So that we can say that there's no interruption in supply chain. And so you have to resolve the supply chain disruption problem. So this is the now time we have to think how we can create the smart, agile, industry-driven supply chain is a key to building global trade and investment network that is capable to face this kind of future storms if we face again. Thank you so much.
Thank you so much, Dr. Mamun, for such an insightful presentation. We now move on to our next presenter, Dr. Mohammad Sarwar Hussain, Associate Professor, Department of Environmental Science and Management. And he is going to discuss COVID-19 and COVID-19, food and security in Bangladesh. Sir, your microphone is muted.
Can you hear me?
Yes, sure.
So I'm going to share my slide. Can you see?
Yes, sir.
Good afternoon, everybody. Thank you for inviting me. So this is, and we are in an unprecedented time of our human history. And because of a tiny virus which has stopped the world, and we are forced to stay at home, and the way of life and the thinking, everything got changed forever. So today I'm going to talk about the COVID-19 pandemic, what happens in last 7 months in Bangladesh. So I'm going to present out some data uh, to get an idea how the outbreak is unfolding. Next. Next, please. Excuse me. Okay. So this is a collaborative project which started by a non-profit organization, Biomedical Research Foundation, Independent University, and National University of Singapore. So how COVID-19 pandemic was evolved in Bangladesh. So to start with that, because there was a series of events which occurred knowingly or unknowingly, which lead to spread the virus across the Bangladesh. Here is we tried to map what went wrong or what are the events. So actually, first case was declared in March 8th, and then school closure, then lockdown. So you can see this part. This is lockdown period, 66 days lockdown, and then there are lots of events happening, especially for anthropogenic. At the same time, uh, uh, natural disaster like Ampan, a cyclone which caused 5 million people affected actually for that. So all these events, mosque closures, university closure, and then and all this are not proper, because when first case was declared, or in China, because you have a good relation with China and Bangladesh, actually COVID-19 was first isolated or reported in November. But by this time, the declaration and this the first case in China, it's a long time, and there are no such restriction in the airport or any port, seaport. So it, and recent study shows that actually first case was actually in Bangladesh in February. The recent study done by ICDDRB. So anyway, so we had lots of opportunities, but we missed that. So if you see this graph, it's a human mobility data. We got it from the Google, and it shows that this is all over Bangladesh. When lockdown was, when first case was declared, everybody gets scared, and all the panic broke out, and everything get standstill, stop. So, and when government declared it's a national holiday, actually it was a big mistake. It should not have labeled as holidays. And then lots of people just start moving out from the Dhaka. So all over the period during lockdown, actually there are lots of events, human mobility was recorded. At the first, due to panic, you see less activity, and gradually it is increased. And then during Eid al-Fitr and Eid al-Adha, two events, you see the big peak. So that is, there are lots of mobility, and you will see every time after Eid there was a huge outbreak. So it shows that, and if we could have data from Dhaka, that the graph would be even much better. So this shows that the although there is a lockdown, still there was activity. So, and gradually in last 7 months, so it started in Dhaka was the epicenter, and gradually it spreaded all over the country. So, and this data is from up to September 10. So what went wrong actually? And our study have found that although we have lockdown and restriction, but those were not effective enough. There was a miscommunication. It's called crisis communication or public health communication. And because the COVID is such a new thing, everybody was just perplexed what to do. Even WHO and all those countries go for lockdown, and recent study shows that, or recent recommendation from WHO, they are telling not go to lockdown. Just it's not effective. If you consider economics and everything, we should have better strategies considering their every country. Not one policy is good for all over the world. It depends on many things. So if you see our the incidence and mortality, males are disproportionately affected. If you infected, more than 70% cases were reported for men, and more than around 80% death was male. And the age group was like 20 to 30. This is the most highest age group where people get infected. And if we see the age was a factor, the death was occur 4 times higher in the people with old people 60 years plus. So if you look at a pattern of disease severity, only around 3.4% was reported severe cases in Bangladesh, and there are some moderate, and there are some mild case. And recent studies in Dhaka, it's not published yet, it shows that around 48% population in Dhaka got infected already, exposed to virus. The data was taken from April to August, end of August, uh, or end of July. So by this time, many more people get exposed to viruses, and you see there are some disease comorbidities. Most affected group was the people with diabetes, heart disease. And this pattern is similar all over the world. The risk factor is the old age and with comorbidities. So we have also collected some data from unofficial COVID death, which it's called deaths with COVID-like symptoms, which are not laboratory tested case. But this data was collected from Dhaka University Center for Genocide Studies. Up to September 10, there was 2,000 plus unofficial COVID death in Bangladesh. So, and there is the frontliner workers. Those consist of doctors, nurse, medical staff, police, army, journalists. More than 20,000 frontline workers get infected, and 100 plus medical doctor died. 50 police died because of COVID. And then there is no other. This is based on available information from the newspaper or press release, but there is no such report for nurse. Only you can get reports for medical doctor. I think from this table it shows that inequalities in our countries, because those who have the power or influence, they can show their influence through even through data. But those people who are, I call them marginalized in health sector, especially the nurse, because not, they are the most exposed group in the hospital, because they spent most of the time with the COVID patient, but no such data. Nobody took data for them. So if you look at the mortality rate, it's surprisingly low. And before COVID started, there are lots of models about Bangladesh, and then people used to get panic that thousands of people will die, and then it's a dead body will be on the street. But actually, that doesn't happen. Why it doesn't happen? We still don't know. There are many factors, and this scenario is not only for Bangladesh. If you look at whole Asia, overall mortality rate is much lower. Even the Indonesia, Malaysia, Thailand, um, Vietnam, I think most Asian countries have lower mortalities. I think it's related, it could be linked with lifestyle factor like less obesity, food habit, or physical activities, which linked with better immunity. So if you see in South Asian country, Bangladesh is mortality 1.4. So, and UK or Latin American countries like
Sir,
Brazil.
excuse me, you have 2 more minutes, sir.
Okay, I've almost finished. So that means mortality is slow. Even I take information from the graveyard also, but there is no such um, unusual death report from the graveyard also. And if you see, look at the graph trend, so it seems that COVID case is decreasing, but the irony is that the test per case, test positiveness almost similar. That means COVID outbreak is not going down yet up to September 10. That means it's a down case, but the test positive rate was almost similar. So that means we are still in first wave of the pandemic. So even the test per million population is less in Bangladesh, and even some countries even less, Vietnam or Japan, but they have the good quarantine or all those management system is better. So that's why, and in terms of testing, Bangladesh is quite low. And how COVID pandemic linked with food security. The earlier presenter already discussed the supply chain is a big issues. And if you see, because of COVID-19 in Dhaka, 68% people lost jobs in Chittagong. This is recent study from World Bank, and and you see lots of projected job scope. It's decreasing, agriculture, textile, all this, because food security is linked with four pillar like availability, which is linked with supply and demand, which is affected enormously, and also you have access decreasing purchasing capacity, all these are affected. So the impact of COVID, if so, the overall situation is COVID is uncertain. It could stay like another 1 or 2 years. So take home message for all our studies is like, first of all, the failure in public health preparedness and communication. This is a big area to work on it for future outbreak. Males were affected more, and for South Asian countries, mortality rate was surprisingly low as compared to Western countries. Case fatality rate was really higher among frontline medical workers or law enforcement officials, and significant job loss due to COVID pandemic, which is linked with food security. Thank you so much.
Thank you so much, Dr. Sarwar, for your presentation. Ladies and gentlemen, the Strategic Executive Group working with us, the ACG actually, is working with its blueprint, the Joint Response Plan, to provide the humanitarian assistance to the Rohingyas, and the International Organization for Migration co-chairs the ACG. And today we have with us Dr. Marcela Nawaira, Migration Health Officer, COVID-19 response, and she'll be joining us from Cox's Bazar, and she'll be talking to us on COVID and the Rohingya camp management. Dr. Marcela Nawaira, please welcome.
Thank you very much, and good afternoon, colleagues. If you allow me to share my screen, I've prepared a very brief PowerPoint presentation.
Sure.
Let me just find it. I hope you can all see my screen.
Sure, yes, we can.
Okay, can everyone see the PowerPoint presentation?
Yep.
Yes.
Okay. Thank you very much. So as mentioned, we're actually currently in developing the joint JRP, or the Joint Response Plan, for the next year for 2021. And in it, we've actually seen that how, as the pandemic has carried on, it's been ever changing on the ground. And we've realized that one of the key important things for us to do and realize as the health sector is to try and integrate the COVID-19 response into the regular health programming. But that's an aside for a different plenary session. So without any further ado, I'll just present this presentation that was scheduled for this afternoon. So in the beginning of the crisis, we modeled our response to the Rohingya refugee camps based on the 9 pillars of the WHO COVID-19 response. And our key thematic areas of work have included case management, surveillance and contact tracing, support to testing and laboratory, risk communication and community engagement, infection prevention and control, and operational and logistics support, especially coordination with partners. I've put at the end there capacity building with an asterisk because that's been a major part of our growth, though it's not one of the mandated pillars of the WHO plan for COVID-19 response. So beginning with case management. Now, IOM covers about 35 or 50% of the camps here in Cox's Bazar. And within our response in the case managed pillar, we've managed to construct or establish 3 SARI ITCs, or severe acute respiratory infection, isolation and treatment centers. If you can see the table clearly, we've managed to actually reach a bed capacity of 214 and managed to recruit enough staff for there to be a 1-to-1 ratio between medical staff and patients admitted in the ward. All these facilities have been established with triage and screening wards, as well as the wards for suspected and also confirmed cases. And we also established specific referral pathways and stabilization rooms as well. IOM now leads, part of the most important parts of case management is adequate and timely referrals. One of the key challenges, especially amongst the Rohingya refugees, is actually transporting a potentially severe case from the camp to an ICU facilities which are not available within the camp. Hence the formation of the dispatch and referral unit, which is a centralized ambulance dispatch center led by IOM that actually coordinates ambulance in the entire sector. So it's actually a hotline that functions within Cox's Bazar, and any camp or camp level hospital can call this number, and from there an ambulance can be dispatched to the community and the patient can be taken to the relevant SARI ITC or ICU as the case demands. The dispatch referral unit also works as a live COVID-19 isolation bed capacity. So it's actually one of the health information management or data tools that's been developed that enables us to monitor exactly how many beds are free or how many beds are occupied at any given time. So this has taken a lot of coordination for all health partners on the ground, and they always feed in their data on a daily basis. So at any given time, we know exactly which ITC has beds available and how many beds are filled. I'm not sure if you can see the dashboard clearly, but you can see that the DRU does not just transport COVID-19 cases, it also transports contacts. We have a dead body carrier. We also transport humanitarian workers for testing, as well as discharge cases. Now, surveillance and contact tracing has also been one of the key pillars that IOM has been involved in. This has actually included constructing a quarantine facility with 93 shelters that's able to house 93 families in quarantine. In these shelters, we actually also provide food and psychosocial support, because I think you can imagine quarantining a family in a place that's far away from their own homes can actually be quite strenuous. So it's been very important to involve a multidisciplinary approach to assisting the vulnerable populations in these areas. We've actually established many contact tracing networks, and this has been heavily involved, community health workers being trained and surveillance systems being set up, and training volunteers assigned by the site management and site development groups to support medical teams within 13 camps. All our SARI ITCs, as well as some of our clinics, also act as sentinel sample collection sites, and to date we've collected 5,710 samples from refugees. One of the key pillars in the WHA response that's actually very understated is risk communication and community engagement. It's a very, very important aspect of the COVID-19 response, and it seems to be the bottleneck of the effectiveness of all the activities that we've actually put in place. A key challenge has been gaining the trust of the vulnerable communities in the camps, and this has actually stopped us from conveying health messages efficiently. To try and address this, IOM actually formed health outreach teams, which actually involves doctors and clinicians working hand in hand with community health workers and going actually out and into the camps to actively find cases and refer them to health facilities or SARI ITCs. The main aim for these health outreach teams was to enhance COVID-19 community-based surveillance, strengthen continuity of essential health services, and link with home-based care for COVID-19 cases. Like I said, this has been key to try and contribute to building ties within the communities, especially as mistrust and stigma has been a key challenge or stepping stone. And we've been working very closely with some of our partners on the ground, especially with community health workers and community engagement activities, and we've reached over 3,000 beneficiaries so far. IPC, or infection prevention and control. Infection prevention and control is one of the core competencies of the core pillars of the WHO training. And we would try to, sorry, can you hear me?
Yes, we can hear you.
Oh, sorry,
Yes.
I lost network for a bit there. So regarding IPC, we've taken a three-pronged approach to actually trying to reach all the requirements of effective IPC control. First of all, it's training. So we provided training for both health and non-health workers before they actually start working at the SARI ITCs. The training has been relevant to their duties or the tasks being performed by the worker. So for example, if you're a clinician, you've been trained on donning and doffing, as well as COVID-19 management or case management. And for example, a worker, as in the picture on the left, this worker is a cleaner for an ambulance decontamination site, and he has also received his own level of training or relevant topics. So one of the key things that we realize is that there's no one size fits all type of training. You have to adopt and try and make the lessons so that they're able to understand fully and conduct their tasks the best they can. The next part is monitoring. Without monitoring or regular monitoring and evaluation, it's very difficult to see whether or not what you have taught the workers is being effective. So we've actually established that each health facility should have an IPC focal point, and that IPC focal point is responsible for the regular checks, which can be daily or monthly. The second point is monitoring. Once the IPC tool that has been developed has been scored, it's actually, we use a set data tool or a COBO tool, and this is actually loaded offline and monitored regularly using color coding so that the IPC focal point is aware of what is going on. So once daily or monthly checks are being assessed, we're able to easily spot out the red or dangerous areas and respond accordingly. Sorry, my network keeps on cutting. I can see, apologies for that. And then the third way that we're ensuring IPC control is the layout. All of our ITC have definitely designated green and red zones, and we ensure that there's enough PPE stock to ensure the safety of our staff and patients. There's also necessary security measures in place, along with dedicated crowd control and staff to assist with patient flow. I think I will not touch so much on operations and logistics, as one of our colleagues has already gave quite a good talk about that. But we've faced the similar challenges, and I agree with most of what our colleague has said regarding operations and logistics as well. As mentioned, coordination and partnership is one of the key things that has made this response as effective as it is right now. You cannot function in a silo here. You have to work with health partners on the ground, especially to avoid duplication of activities and maximize the use of the limited resources available on the ground. As mentioned, one of the good things about the COVID-19 response is the avenue it's given us for capacity buildings. Most of our SARI ITCs have young doctors fresh from school, and this is their first time actually interacting with patients on the ground. However, because of the funding that we have received, we've managed to build their capacity on a wide variety of topics that they are able to take even beyond the COVID-19 response and use in their daily practice as they move on and practicing clinicians in their lives.
Dr. Marcella, you just have 2 more minutes.
Okay, sorry. So I'm almost done. I just want to say there have been challenges, but we've actually tried to confront them as opportunities as well. In case management, one of the key challenges was especially in March, April, at the beginning of the COVID-19 pandemic, when it was declared, the case management and the ever-changing definitions and case definitions, this was happening almost monthly. So we had to do refresher courses for our clinicians on the ground and our frontline staff on a monthly basis even. Surveillance and contact tracing had also been quite a challenge in the beginning. This is before we had the pre-positioned PPE in stock in order to protect our health workers as they go out into the community for finding cases and following up cases and contacts. Testing and laboratories, similarly, we had a challenge initially with
Maybe Dr. Marcella is facing some network problem. Thank you very much, Dr. Marcella, for joining us. We just move on to the questions that we have, question answer sessions, and we have lots of questions for our panelists today from the students at IUB and whoever is watching it out there. I would now like to hand over this question answer session to my colleague, Hussein Ahmed Tawfiq, who will be coordinating the question and answer session with the students. Tawfiq, over to you.
Okay, there are several questions for Dr. Hussein and Dr. Mamun. I would like to start the first one, which is directed towards Dr. Mamun. The person's name is Tariq Nur Al Chaudhuri. He asked to Dr. Mamun that due to COVID-19, Bangladesh received PPE supply orders from USA, which used to be supplied by Chinese manufacturers. What do you think how we can utilize these new opportunities by Bangladesh replacing China in the supply chain?
Thank you so much. It's a good question. You know, after the COVID-19 situation, we call it post-pandemic, everything will be changed. All business phenomena will be changed. Global politics will be changed. Financial condition will be changed. And what was the position earlier, the USA and the UK, and after the post-pandemic, it will be we believe it should be deteriorated in terms of the financial condition. On the other hand, like our subcontinent, yeah, I think in my lecture I also mentioned that now they're also planning to move to the like the Apple's store to the like a subcontinent like India and other country. So PP is one of the example is that they have to ask this kind of supply from Bangladesh. In fact, earlier the U.S. Donald Trump, when he took the position as inaugural session, the T-shirt and also the cap was produced in Bangladesh. But problem is that usually we are getting this order by the merchandiser. Therefore, even our side, the workers, the organization, we do not know who the real customer will be there. But this time, due to the PPE, the supply situation, they are not dependent on like any merchandiser. They're giving the order to Bangladesh directly. I hope that is some kind of opportunity for us. You know that we always mention in supply chain, COVID-19 also creating some opportunity for for our situation. And I believe we have to take this opportunity for future as well. Thank you.
Dr. Mamun, you have two more questions. I think you can answer it briefly. The first one is made by Abrar Mahmoud. He's saying that what might be the solution for the challenge of monopoly in natural goods as stocking them in warehouses and price hikes in this pandemic? Will any better supply or strategy may work? The second question is from Nadrifa Raida. Most countries are allotting resources based on a model where resources are allotted to institutions where there are better returns. I'm not so sure whether that is a question or an opinion, but you can respond.
So, yeah, thank you so much. The first one, what you asked, this one, that even that this is the initially even the big company like if you talk about the like Tesco and Walmart, they're planning that they have to do the raw materials for the in the inventory. They have to do those, we call it in inventory and supply chain term, stockpiles. So they'll keep the stocks, but the question is that how long it will be there. It is not possible for a long time can be there. So that is not the solution as well. So what could be the solution? What I said earlier, just in time is a better service. After the COVID-19 started, the Walmart and Tesco, they changed the mood of their business. They recruited lots of young people just for the home delivery service. Now people, they love to get the product in the home. So just in time delivery. So they are not waiting for the customer for a long time, for long days. They don't want to keep the product for a long time because if you keep the product in the like inventory or you call buffer inventory, again the warehouse cost will be increased. That is another hampering in the financial hampering will come up in the product price. So it's better to take that initiative, just in time delivery, and don't need to think of the stockpiles, the buffer inventory, what you are using the concept in the supply chain, because is the pandemic is for a long time, like the not only 1 month, 2 months, it's almost more than 7 to 8 months, and even we do not know the destinations. It's better just in time delivery, better that like the home delivery service. What I said earlier, now we have to think from we can produce and from there we can sell there to the nearest customer. So regional based product production, regional delivery would be better. Or whether suppose that we produce the product in the Gajipur, if you think that we should send this product to the like Chittagong area, there's a question with that how we can send this product. The better, why not we can do the production in the Chittagong area as well. So the localized based the production, localized with the sale and everything. Then definitely the warehouse cost will reduce and price will be the more little bit the marginal, and that will be the better benefit for the customer as well. Thank you. Mr. Tawfiq, are you there?
Yes, I'm here. There are two more questions for Dr. Sarwar Hussain.
Yeah.
I'm reading it out from the YouTube feed. One is from Abra Mahmoud. as we know, winter is really contagious for respiratory diseases. Won't it be affecting more than summer in this upcoming winter? And the second question is from Tahira Jahan. Sir, the frontline workers are in the direct line of fire during this pandemic, especially in Bangladesh. How can we improve the inequality that's rampant in the health sector?
Yeah, thank you so much for a nice question. First one is the upcoming winter. What will be the situation? Actually, in any winter, the respiratory or viral disease actually get severe because lower immunity, because not much sunlight and all those things. So, and the issue is what will be situation now in few months time. So it's very difficult to say at the moment, but there is a good thing I feel, because when the COVID pandemic outbreak started last year, at that time whole population was was new to the virus. And right now, in for instance in Dhaka, around 50% more exposed to virus based on some studies. So that means, and the situation, uh, I think it would be not much deteriorating as compared to first outbreak last year, because we have some sort of immunity, and there are some issues for reinfection, but this is not so common yet. There are some reports. So if this happens, it get changes, means a reinfection occurring. That means there is a ominous sign for any vaccines as well. So that means you have to, vaccine cannot guarantee you if that the natural immunity cannot defend properly. So there are many questions. Still we need to wait for that moment, but the one thing is very important. We can use the mask, which can prevent 95% of the infection, one thing. And another thing is physical activity. You know, if you see the COVID outbreak all over the world, so it's a urban disease, and urban people all over the world get infected, but the rural people not much affected all over the world. It's almost common scenario. It could be possible that the physical activity is also matters. If you do physical work, then your immune system will be boosted up, and that's the way we can prevent. And the second question was, I just forget. Can you uh, remind me?
Tawfiq, Dr. Sarwaz is asking you to
Second
repeat
question.
the question, the second question. The second question was from Abrar, I guess. As we know, winter is really contagious.
I have answered the next
Um,
one.
Well, how important is infection prevention and control while trying to gain trust of the vulnerable communities that are distrustful of outside surveillance?
Okay, so there was earlier one question like the healthcare system, that those are infected more. So I think it's a big issues all over the world, and our healthcare structure is not well organized, and per capita healthcare expenditure only $31 per person. And the issue like the infectious disease, it's called emerging pathogen, and it's new, and then all the system get means perplexed and then broke down actually. So at the beginning of the outbreak, even the because of one patient, one doctor get infected, whole hospital was closed down. But the situation getting better now, and everybody is feeling more confident, because by in this 8 months time, there are lots of information already came out from research, and we know how the virus is spreading. I hope we can take lesson from here, the especially if our health is better, and everything will be smooth and fine, because we don't care about our health. You see, the situation get changes. We are now doing webinar from home. We should be in the hall room or seminar room. So we don't take seriously when there's when the before the issue comes. And who knows, the if we are not aware, especially the young generation policymaker, if COVID outbreak go away within say 1 year, and everybody will forget everything. So it's time to take lesson and do set the policy in that way. And first thing, very important, all university, government, everybody must have to focus on research. Without research you cannot do anything actually.
Thank you,
All the
Dr.
decision.
Sarwar. We are
Yeah.
almost at the end of our
Okay.
program. We just have one more question for Dr. Marcella, and it's almost same as what you have just answered, but since the student is asking to Dr. Marcella, how important is infection prevention and control while trying to gain trust of the vulnerable communities that are distrustful of outside surveillance, and what steps are taken to ensure the trust and community engagement from the camps?
Yes, thank you very much for that question. IPC is very, very important in terms of it can actually be a modality of gaining trust. I say this because I had mentioned that one of the key challenges in the risk communication and community engagement activities initially was providing our community health volunteers with PPE. But once you provide them with a mask and some gloves, and then our community health volunteers actually go out in the community, and part of the activities actually is distributing the masks and the gloves, it becomes almost as an exchange of knowledge as well as an exchange of IPC material. So this has been one of the ways that we've been trying to engage their trust. Also, simple basic communication skills like using a translator, sitting on the same level of them, and also trying to understand why they're resistant to wearing masks and why they're resistant to actual social distancing. It just shows that you're interested in their perspective and their perceived risk. And once this is understood, it helps the communication and actually helps them get a buy-in into the whole measures that we're trying to implement on the ground. I hope that answers your question. Just to be brief, I'm aware of the time also. Over.
Thank you, Dr. Marcella. Ladies and gentlemen, it's time that we sign off from this cloud, but we have a very special person to give us the closing address, and here he is, Dr. Imtiaz Hussain. He's the Dean, Acting School of Liberal Arts and Social Sciences and Head of the Global Studies and Governance Program at IUB. Dr. Imtiaz Hussain, please share your views.
Thank you. Thank you so much, Jessica. That was a fascinating and one of the most factual panels I have heard in many, many years. I must say that. Each and every one presented something very substantive and of enormous future relevance. Typical panels are about abstractions or theories, but this one was all about practicalities and prescriptions. What benefited us the most are the way it promoted potential innovation in both policy making, but also pandemic curbing. And so doctors Mamoon, Marcella, Meghna, and Sarwar, I think each one of your papers um, completely fact-filled and substantive. And I would like to push you and even encourage you, if you can make a chapter type of a submission, we would love to include it in our volume on the subject. And Jessica will get back to you. I particularly think Dr. Mamoon's theoretical explanation, all the definitions and the processes, very eye-opening for our students, our main consumers of information. And if you could perhaps translate all of them through our own RMG, which is right now going through a huge transformation from low-wage physical labor to automation. I think that might really resonate with the public out there right now. And certainly the two that are on the Rohingya camp, Doctors Meghna and Marcella, I think there's a lot to be learned. And not enough of that information is coming out. We have the platform, if you would like, Dr. Marcella, come and share the information with us, that would be just absolutely fabulous. I liked Dr. Sarwa's presentation very much. It is so concurrent and it encapsulates everything that we are doing, hearing, and living here in Dhaka city. I think there is something there that might be of enormous value to a lot of people in other countries as well. And Jessica will be back in touch with you so we can all put these together for the greater benefit of not just IUB students, but the public at large. I think there's a book possible, and I would like to thank each one of you participants. I would particularly like to thank those who made this happen so successfully, beginning with lecturer Jessica, but behind her, the whole army of lecturer Tawfiq, lecturer Amjad, there's Dr. Marufa, and a whole string of our global studies students, the majors. Many of the questions came from them. So good to hear you. And the questions that you ask, you're listening, you're following, it shows interest because this issue, COVID, the pandemic, is not going to go away just like that. It is going to be around for some of you even when you graduate next year. Please see if you can extract more mileage out of everything you have learned and get in touch with all the experts you have met, that you have heard today, and see what you can do for your own country and thereby the people outside. We really are so grateful to all the international organizations coming into this country, going into the direst part of the country, helping out the refugees, for so long, so persistently. We really thank you so much. And Dr. Marcella, you can convey that message. Anything that we can do for you from IUB Global Studies, do let us know. Please stay, those of you who can, for the next panel, which is the last one of this Global Day um, celebration of ours. Thank you so much, and may God bless you all.
Thank you, Dr. Imtiaz Hussain, for your wonderful remarks. We are all at the end of our discussions, and as I said, it's time to sign off from our panel. I take the opportunity to thank all of our esteemed panelists who have joined us and shared expert insights. Most importantly, I thank all of you, our students there, for staying with us. But before I leave, I would like you all to ponder. The pandemic demands a coordinated whole of the globe approach with powerful conductors at the international governance level. If that does not happen, do we switch on our OTT platforms, say Netflix or HBO, and dive into Interstellar to find a habitable planet? No. You don't need to have astrophysics degree for that. If you are still pondering, just drop by to IUB's GSG program and we will show you the way. Till then, stay safe and maintain the social distance. Good night and good luck.